Hi guys, for chapter 42, this is the one that I will have two questions on the test, so we'll kind of drill down to those. But if you look at our objectives here, we're looking at those antifungal drugs, some of the things that we always look at, how they work, when we use them, contraindications, etc., and then the nursing care plan for these drugs. I'm kind of glancing over this part, fungal infections. We've talked about bacterial infections and we've talked about viral infections. So this is yet another one, which is a fungal infection. And we will typically see these, if you look right here, this where we have systemic fungal infections, when we have people that are immunocompromised, which we've said with our bacterial and our viral infections. So nothing new to that. And we'll look at some of the specifics down here. I'm going to go straight to the indications with this, and we're looking at 3 different drugs with this one. We're specifically looking at amphotericin B, diflucan, and mycostatin. So when we look at our indications on this one, we note first that amphotericin B is used for the wide range of fungi. That one's the more powerful one in this group. And then we'll talk about nystatin when we look at oropharyngeal candiditis. I think about baby thrush with this one, or used as a topical powder. Typically where I've seen nystatin, if it's not used for thrush, is when women with large pendulous breasts have yeast infections under their breasts, so we can apply it in that topical powder there for them. Some of the adverse effects of our fungals are drug interactions and hepatotoxicity. So again, think about how we're evaluating both of these, and we've got a nice table here that's going to show us some of those adverse effects. I did want to point out, because they do have so many adverse effects, that we do a lot of pre-medication before we give our antifungals. So antiemetics to cut down on that nausea, vomiting, antihistamines to stop that inflammatory reaction, antipyretics for the fever, and then corticosteroids also to help decrease those reactions. And then also notice that we can decrease those reactions if we slow down the infusion time. Amphotericin being the one I think they're specifically talking about there, because that one's typically given IV piggyback or IV piggyback. So we would do that in a slow IV piggyback over 2 to 6 hours. Look at some of those adverse effects that are specifically linked with amphotericin. So cardiac dysrhythmias, which would mean I would check for that heart rate. I anticipate them being put on a telemetry monitor while they're on amphotericin. Can also have some neurotoxicity and tinnitus. So understanding a good baseline of your patient's CNS would be important. And then noticing that tingling or pain, so assessing them prior to giving would be important with that one. Renal toxicity and potassium loss. So renal toxicity, we've talked about this several times, making sure we're checking that urinary output and looking at that potassium level between 3.5 to 5 with that individual. And then for the nystatin, it can cause a rash and urticaria with that. Again, pre-medicating for both of these drugs is going to decrease that. I've really only seen the pre-medication with amphotericin B, but pre-medicating prior to hanging usually is noted on your MAR. When we look at drug interactions for our amphotericin, can induce that hypokalemia, which can potentiate or can lead to DIG toxicity. So if your patient's on DIG, we're going to note their potassium level while we're giving the amphotericin, making sure that's within the normal range, and then watching for those signs of DIG toxicity. Remember those halos around the lights and visual disturbances being some of the common ones that we see with that DIG toxicity. And then again, noticing that hypokalemia can come if they have any of the thiazide diuretics. Notice how it works with my interaction with oral anticoagulants, increasing those the effects of those anticoagulants. So again, thinking about higher risk for bleeding with those individuals. And then with my oral hypoglycemics and my statins, it's reducing the metabolism, so it increases the toxicity of those 2 types of drugs, those hypoglycemics and my statins. So monitoring for that. Then when we look at those 3 drugs in specific, and again, I'm getting this off my meds to master these 3 drugs right here. For my amphotericin B, they use it when they need it because it is such a strong, effective drug for treating those fungal infections, but it does have a lot of adverse effects, so they have to weigh the benefit against that. Notice that when we give it IV, patients can experience that fever, chills, hypotension, tachycardia, joint pain. Look at all the things they can experience there. So we usually do that treatment with antipyretics, antihistamines, corticosteroids, and when we give the infusion, do it over a longer period of time. I've seen that one on a HESI question. Down here in the 3rd paragraph, we talk about how it can cause, or if you have an individual with bone marrow issues, such as, think about my cancer patients, that it can cause that bone marrow suppression and renal impairment. So think about getting complete blood count on those individuals so I can monitor their blood levels and monitoring that output on them. We did mention that amphotericin is available IV. Sometimes we give a test dose to see how they'll tolerate the drug, and we almost always pre-medicate before the amphotericin. I'm going to scroll down to diflucan, which is my next one. Because it doesn't have as many adverse effects, sometimes it's given instead of amphotericin. I usually think about it being very effective on vulvovaginal candiditis, so on yeast infections. One of the benefits of diflucan now is it can be given in a one-time dose, which is very great for compliance. We also want to make sure that if we're teaching females if they have vulvovaginal candiditis, that they are abstaining from sex until that's cleared up, or if they choose to have sex, that they protect their partner so that they don't transmit that. Moving on to nystatin, which is our 3rd one in this one. So nystatin, mycostatin, we usually see this on diaper rash, or we can also do it prophylactically for patients. I think about my cancer patients I've treated before. We use it prophylactically to prevent them from getting oral candiditis or oral thrush. When we do this, we'll get to it in the assessment, but we usually call this a swish and swallow because it's usually a liquid that they will swish and swallow in their mouth to prevent that oral thrush there. We're going to scroll down to the nursing process here. So on our amphotericin, we want to make sure they don't have any contraindications before they take it. We want to look at those baselines for renal and hepatic functions because we know it's highly linked with that nephro and hepatotoxicity. We want to make sure we're not giving it concurrently with other nephrotoxic drugs. Then we want to make sure we're monitoring for those cardiac dysrhythmias, headache, chills, hypotension, GI upset with that IV administration. Making sure if we do give it IV, we're giving it slow IV, making sure we're also giving it via a pump. They're going to still kick in that pre-medication. So we talked about the pre-medication 3 times, so that's an important facet with that amphotericin there. And then scrolling down to my implementation, we mentioned giving that amphotericin IV. There's a couple of things here under that. We usually are provided an inline filter from the pharmacy that we'll utilize with amphotericin. Monitor that site for extravagation, so make sure it doesn't become infiltrated. Making sure that the liquid is clear and it doesn't have any precipitates or it's cloudy. Use a pump. We don't want to do this just free hanging. We want to make sure we've got it on a pump. And even if we've pre-medicated, when we first start our amphotericin, we're going to monitor their vital signs every 15 minutes, especially paying attention to cardiac dysrhythmias, visual disturbances, any paresthesis that we might note from that individual. It does mention if we have a severe reaction that occurs, we want to stop the infusion immediately, monitor the patient, contact that prescriber. It does have a little bit of things about if we think there's phlebitis and what we would do with that. Monitor my intake and output, which is something we do with all our nephrotoxic drugs, and then monitor my lab values post giving the amphotericin. Scrolling down to that nystatin, usually that's given orally. It's typically in a lozenge or a liquid. When it's in the liquid form, we want them to swish it around their mouth and then swallowing it. Swishing it around their mouth helps coat the inside of their mouth so that it prophylactically treats those immunosuppressed individuals and keeps them from getting that oral candiditis. Under our evaluation, we want to make sure that as the fungal infection decreases, the patient's feeling better, so they'll have resolved signs and symptoms of that fungal infection. And look here, this is one of the only places in our textbook you'll see this. So they have improved energy and sense of well-being with normal normal temperature, and other vital signs indicate that therapeutic response. This is one of the only times you'll see that increased energy level, because it's so difficult for your body to fight those fungal infections. Good teaching instructions here, especially about when you think about what we're responsible for as the nurse when we're giving our medications, making sure our patients are aware of these patient teaching aspects. This is all on chapter 42. The next video will be for chapter 43.